So today we're going to talk about documentation and reporting of patient care. And I guess I'm the person that should talk about it because I'm the utilization review nurse and I do all the auditing of charts and look at everybody's documentation. And so I'm the perfect person, I guess, to talk about this. So, you know, you probably don't realize how important your documentation is. It's very important. A lot of people look at it. You may not realize that a lot of people are looking at what you are clicking into your phone. I don't know what kind of documentation you do. Use yours on paper? In private duty? Yeah, you do it on paper. And here in hospice and home health, they do it on their phone, so it's electronic. So it's really important to remember that any documentation that you do about what you do for your patient is it's a permanent legal. Your chart is part of the chart, and it's a permanent legal document. And it's a record of your patient's care. And worst case scenario is it could actually end up in court. So I've been a nurse for 40 years. As far as I know, at least I've never been in court. None of my charts have ended up in court, so you don't know. You know, maybe it won't, maybe it would. You don't know. That's why whenever you document, you want to make sure that you're doing it completely and correctly and always covering yourself, because whatever you put in there is evidence of what you're doing for your patient. So you're actually serving as the eyes and ears for the rest of the healthcare team, and the rest of the healthcare team is the doctor, the nurse, the case manager, the social worker, at least on the hospice team. And so everybody's observations together help the team make the necessary changes in each of the patient's care plans. So the information that you report, either on what you document on your chart, your care plan, or if you call the office or to give a report to your nurse, or some of you, at least in the hospice, I'm most familiar with what's going on in the hospice. Maybe you come to IDG, and sometimes I've been in IDG when the home health aide actually gives a little report during IDG. That's when all the team meets together and discusses the patient. Those kind of things help us all to know what's going on with the patient so we can give the very best care to that patient. So, and that affects the care that the patient gets. So I don't know if you know that when your supervisor does your annual review, that they look at your documentation. They look at what you do in your documentation, and that's part of your annual performance review. So reporting about your patient gives you a chance to demonstrate your professionalism. So all your patient telephony care reports, that's what we call it in hospice, they call it their telephony care report, must be kept confidential and filled out on each of your shift's work. So you really should fill it out right after you finish your care. Now I understand when you go to a facility and you have more than one patient that you might want to wait until you finish, say you have 2 or 3 patients. And I can understand that because I know you're in a race. Sometimes you have to get them done before breakfast. That's fine. But when you're going from home to home, the best time to do your documentation as soon as you finish the patient. Because if you wait till the end of the day and you've done all these patients to do your documentation, it's not going to be as good as if you do it right when you're done, because they're all going to start to blend together. And you're not going to do the best job as you would do if you do it right when you finished. because it's going to be all fresh in your mind. You're going to remember everything better what you did. So why is clinical documentation important? And because it allows members of the health team to communicate with each other so they can work together to give good and safe patient care. And also it serves as, like I said before, legal evidence that you performed your job as you were directed. It also provides a place to record changes in the patient's care plan. And it also helps healthcare organizations meet the requirements for licensure and accreditation. It keeps a record of the services provided to each patient so that our workplace may receive payment. So you don't know what happens behind the scenes here in the office. You know, some of our patients, we get paid by Medicare, and we can have periodic reviews. You know what happens when we have a survey, when they come in to take a look at us. Sometimes Medicare might send us and say they want to look at a chart, so then we have to get all the paperwork together, and that includes home health aid documentation on a certain patient. We have to send it all into them. They want to see everything. Or there might be insurance that might be covering a patient that we have. And they might be authorizing one benefit period at a time, and before they'll authorize, they want to see what we're doing. And so all of that goes in to them. Just remember that our documentation can be read by a number of different people, including our co-workers, supervisors, doctors, other medical providers, quality improvement personnel, Medicare and insurance company reviewers, could be lawyers, could be social workers, judges, and family members, just to name a few. So you want to take time to write notes neatly, specifically, and completely. We also get requests for records from family members. They want copies of the chart. And whenever that comes in, a request, I have to go through and look through the chart and make sure that everything's okay. We're not missing anything, or before that we make a copy and send it to them. Because they have, you know, they're the right person, and that's their chart. Or if they're a DPOA or whatever, they can have copies of their chart. So what should be included in your notes? The tasks or the services that you provide, your observations, if you've been assigned measurements like vital signs, weighing patients, any safety issues that you're supposed to be observing for, like fall precautions, skin breakdown. If you see any safety issues like faulty electrical equipment or anything that could hurt your patient or, you know, be a source of injury, we're responsible for that. Any patient statements or complaints or any unusual events. Has anybody in here ever had to fill out an incident report? Do you know what an incident report is?
Yes. Yes.
Yeah.
Somebody, we all do.
Yep, I've had to. If you have to fill out an incident report, doesn't mean you've done anything wrong.
Yes.
You know that.
Usually can witness something.
Something that's out of the ordinary, a fall. A lot of them are falls.
You need a record of that.
Yeah.
I did one when I was in San Bernardino. I went to see a patient, and in the neighborhood there was a gunshot. And I called, then the supervisor was Kathy Overland. And I called Kathy Overland where I was, and that there was a shooting, and police were coming over, and she told me to stay there and not leave until she tells me to leave. So 30 minutes after she called, and I told her I'm still with the patient, the place is swamped with police. And
That house where you were at?
it's an apartment
Oh.
in San Bernardino, and I was in the middle of the apartment complex. So the police were everywhere. I couldn't go to my car. So they were looking for who did the shooting. They found that somebody on the floor. So they were trying to trace where the bullet came from and everything. So I was in the house for almost 2 hours.
Wow.
And then I called Kathy and told her, and she said, if it's not safe, don't step out. So one of the police officers, they came knocking on the door to ask, did you see anything? Did you see a gun? Did you see somebody running, somebody shooting? Well, I didn't see anything, but I heard the gunshots.
Mhm.
And I said I didn't see anything. So when I went to the office, Kathy told me to write. an
You had to
incident
write it?
report. Yes.
Mhm.
But nothing happened to me. I didn't see anybody. I only heard the gunshots.
Mhm.
And it was so close because we felt it.
You felt it?
Yes, it was very close to us because we felt it in the house. Not only the sound, I mean the vibration, we felt it.
Oh, wow.
Well,
Well, that's something I'll never forget. That is. Wow. Boy, that's scarier than anything that I've experienced.
You know, when we heard it, I didn't know it was a gunshot, but the patient told me it was a gunshot.
Oh, okay.
But it was loud and we felt it. I mean, it shook us. And she said it must have happened in this building or the next one for us to feel it like that.
Mhm. Yeah, well, that's definitely something out of the ordinary, so. Mhm. Yeah, so an incident report doesn't necessarily have to be something that happened to the patient. It's something that happened to us. So if we had a fall while we were working, like if you slipped while you were working, that would be an incident report too. So, anything like that. Okay, anybody else have an experience?
You know,
That was
sometimes
unusual.
when things happen to us, people don't know it's something they need to write an incident report. But
Well-
it's always better to call the office immediately.
That's what I was gonna say, if you're not sure, you should always call the office and ask the manager if that's something that needs an incident report. Okay. And when you're writing an incident report, when you're doing it, someone can help you, because when you're writing an incident report, you're writing a story, but you're just writing the facts, only the facts, not what you think, but just the facts. And that's when you're writing observations about your patient, you're just writing the facts, what you observe. You don't, we have subjective things and we have objective. Objective are the facts, subjective is what we think. And so when you're documenting, if you're documenting something that your patient is saying, you should always document in your patient's words, not what you think they said. You don't turn it into your words, you document what they said. If the patient says, I feel sick today, or if they say, I feel bad today, you wouldn't document the patient is feeling sick today. You would, because now you've turned it around, you're interpreting it for them. You say exactly what they said. I feel bad today. The patient states, I feel bad today. Okay. Okay, so when you're making observations, the facts are things that that with your eyes you can see things, that you can see what a patient is eating, what they're drinking. You can see that they're ambulating, you can see that they're dressing, you can see their toileting, you can see their body posture. Those are facts. You can see their skin color, you can see bruising or swelling. You can see their breathing pattern. You can see what bowel movements look like, the color, amount, and consistency, the urine, again, the color, amount, and frequency, facial expression, so you can see smiling. You wouldn't say that the patient's happy, you could say the patient is smiling. That's a fact. Frowning, grimacing, or crying. With your ears, you can hear things. You can hear raspy breathing, you can hear coughing, sneezing, crying, or moaning. You can hear the blood pressure. So blood pressure is a objective symptom. With your nose, you can smell symptoms: breath, body odor, urine, bowel movement, vomit. With your fingers, you can feel a client's skin temperature, skin texture, pulse. So making observations involves using the four senses: sight, hearing, smell, and touch. So state objective observations as facts and write subjective observations as statements in quotation marks. Okay. Okay, I wanted to also talk about the telephony care plan documenting. Because that's, sometimes I see a little inconsistency in the documentation in the telephony care plan, because it's a little bit crazy sometimes. On our, you don't have the privilege of really documenting, because you're actually choosing an answer. So I was trying to remember all of the reasons when you put not completed, and these are the ones that I came up with, and you tell me if any that I missed. That when you put down not completed, you have reasons. One is no issue to report, task already performed, supplies not available, patient caregiver refused, care plan needs changing, right? What else? Did I get them all?
And joint visit,
It's already done by the
it's already done, but it's like the last one, right?
yeah, they do it.
What is it?
The joint visit done by joint visit,
That's already,
how does it go?
like something like that's already done by the joint.
By our joint visit.
Comb the
Done by
patient,
joint visit?
comb the patient's hair. He doesn't have any hair, he's bald, so what do you put?
No issue to report.
No issue, I mean, what's the right answer? No hair, shampoo his hair, whatever you can do with scalp, but when you don't have any hair,
Blow
it
dry
says
and
blow
send
dry the hair, comb the hair and stuff
So
like
no
that.
issue, no issue to
Why
report.
in the world would they put down comb hair?
Exactly, that's what the majority of them all have it
They
on
put
there.
both, huh? They put comb hair and then also put dry and set hair, both.
Blow dry on somebody
No,
who's
one
doing
is,
set hair.
they put different.
Blow dry, yeah,
Blow
set the
dry and
hair.
set the hair and comb.
And then
hair.
another one for the comb brush.
I just mark comb. And the other one, no issues to report.
Blow dry.
I
But we
would
don't
say-
set the hair, we just comb.
I would
it.
say that the answer needs to be
Comb
care
hair.
plan needs
That's
changing.
old.
They need to change.
I think it need, the right answer is care plan needs changing.
It's like clean the dentures, well, you can't do it because you don't have it, you can't put his teeth in his mouth anymore. So you just swab it out, but you can't clean it. So, especially when the patient's applying it.
I think there's one also.
And then when there's a problem like that, then I think the answer should be care plan needs changing, and then there needs to be a mobile care note made, and it should state in the mobile care note that for the one that say dentures don't fit any longer, patient needs swabbing of mouth. And that goes to the case manager.
Okay, what about the case manager, she doesn't change the assignment, and you go back and see the patient, you have to make the note again, the same note, or just ignore it?
And the case manager's not answering you or responding.
And you go back to see the same patient,
Mhm.
and,
Then, you know,
because that happens a lot.
okay, if that happens, then I say you just email me.
Okay.
Yeah, because there are a lot of things in the care plan. Okay, for example, we call them, this patient used to be a shower before. Then when we call them, this patient is a bed bath. there is no need putting bed bath and leaving the shower there. They're supposed to delete the shower
Right,
and,
still need it.
and leave the bed bath.
That's
But
right.
they still
Okay.
leave the
We're
shower.
we've
and,
talked to them.
You know.
You cannot have two types of baths in the care plan.
They
We've
still
talked to
have
them.
them.
Still do
They
it,
still
they
have
have it, they still have
They
it.
still have it.
Forever and ever.
Sometimes.
We just talked to them, so it's gonna take time to get that out of there. They are now supposed to, every research, they're supposed to go in and
Update it.
review.
That's what I think. They're
Sometimes
supposed to
the
check those
patient-
things and delete whatever that is no longer applicable. But they don't. Instead, that's why we always say tax, nothing to report, because we're not doing it anymore. And we don't have anywhere else to put anything than to say, nothing to
And
report.
sometimes the patient become bedbound and they don't change the assignment, it's still transfer with a sister, you know.
Uh-huh.
Ambulate.
Still shower?
You know,
Yeah.
device, and they don't
No,
change
it's
the-
not shower. Like we used to transfer the patient before. Then now patient become a bed bound. They're supposed to kind of delay the
Patient bed bound.
transfer
Exactly.
and leave the bed bound. But both of them is still there. Patient transfer, assist to.
Ambulation.
Two-person
Two-person assist, ambulation to the bathroom, all those things, you know.
If you will not gonna say something and you will not gonna add note, it will not gonna be addressed. But if you already know that the telephony care plan is already updated, you still have to add notes and then they,
Oh, they are.
that's what you said, you have to tell them.
Just like how many times?
All my patients
All
are
of
like
us.
that.
Okay, but
we
if
have
you're
a
not
patient-
getting a response, then you have to tell
Yeah.
somebody higher.
Yeah.
I will get a response from them. You'll have to tell me.
We have a patient now that the care plan says colostomy bag, the patient never had colostomy bag.
I sure, that was in a
And,
hospital
and we
program.
already told, the nurse.
They finally take it off.
Oh, they take
It's
it
no
off?
longer.
Clean around the IV.
We have to get those cleaned up. We have to get those cleaned up before somebody, from the state or whatever sees those. So you've got to,
We have a prime, a patient. I've been seeing this patient every once in a while when Junior, I cover to see him. It's home health. And it says shower. I've never put him in the shower. I always put it on there, unable to do this. It's two persons. It says you can't do this. And the man's in a wheelchair. But he can stand up a little bit, but he's getting so weak. He's getting so weak right now, but and everything's redundant, it's repeated over. It's like take the blood pressure 5 times on there, take his pulse 4 times on there.
I've
And
seen
it just
that.
goes
Yeah.
on and
That's
on and on
the
and
rest
on
of
and
the home
on.
health side.
I
No,
sent
but
the
it's
note-
done on
I sent the
hospice,
note to her,
Hospice too.
and still nothing. It hasn't been changed.
well then, you can also send a note to the manager,
Okay.
the case manager and the manager. Well, I'm not home health, okay, but the home health manager.
Yeah, they have, I think you are in home health side.
Well,
But I'm not sure who is.
Johnson, even, what did they call it, the environmental concern. How many times have I called you? I got to a patient house,
I
then
didn't
that
even
patient used to be a shower,
Yeah.
okay? Then when I got there,
It's
it wasn't a shower. Then the patient said, oh no, the caregiver said, oh no, it's no longer a shower, it's a bed. I was getting the boot, everything out. He said, but the inside there is still shower there. Then I went through the environmental concern, it's still shower there. Then she was so upset. He said even the daughter, she called the daughter. Then the daughter said, I have told the case manager many, many times to change that.
Yeah, but.
Then I called Jocelyn. I said, okay, let me call them right now as I'm here.
Did I
to
take it?
tell. But I'm just telling you because the way you're saying, the case manager had involved. That family, the daughter had called case manager 3 times. He said she was so upset, That's what I'm saying. So
Yeah, but
which
when
means
you brought it to me, did I take it off?
Jocelyn.
No, no, I asked
know.
if did I
But
think
you
they
don't
did.
just
I
wanna
think
understand
they
what I'm
took it off.
saying.
I think I did that too.
Let me tell you what happened to me last week, and I was very upset about it because it was my fault. And the environment
That's
because
Mr.
I have a patient in Pomona Valley. She was in Pomona Valley, but she was discharged 2 days before. Anyway, I just read the environmental concern. The environmental concern, the patient was at Pomona Valley.
Oh, yeah.
So I went to Pomona
That
Valley
happened to me too.
instead of looking at the assignment,
address.
you know. And so I went there. I feel so bad because I'm asking for this patient. The patient was already discharged.
Yes.
But they told me in the lobby, they told me, oh yeah, she's in room so-so.
Yeah.
That's what they told me. So I went to the
That happened to me too. I went to the 5th floor.
floor 4, whatever, and they were looking for the patient all over. Oh yes, you know, the computer said she's still here, but she wasn't there. So I called Jocelyn, the patient is not here. So I went to the patient's house. But this is just wasting time, misunderstanding,
So
and
what,
then
why,
frustration. I get frustrated.
They should have changed it the day.
They should have changed it.
When there is some changes
Oh.
in the patient address, sometimes the case manager is supposed to update it, but sometimes, you know, they don't. And if I'm not catch them right away, I can delete it. But sometimes it's always there because I cannot catch it. I don't know. Because I'm not breaking the bill, I don't know the patient's still in the hospital. But if I know right away the patient is hospital, I have the chance to redo it and update it. That's what happened to her. When she called
Jocelyn,
me, I
now you
updated it.
telling her you can do it. Most of the time when we call you, you say call the case manager.
Yes.
Talk to the, please, you guys should speak up. It seems like it's only one person. Jocelyn is saying the right thing, that she never follow up. When, most of
Yeah,
the
we
time when
can.
I call
Yeah.
you tell me, oh, call the case manager.
Yeah.
Talk to the case manager.
Okay, this
But
is what
now
I
you're
can
telling
do.
her you do
Okay,
this.
this is different. The telephony care plan, I cannot do anything about the telephony care plan.
But she
Because I don't
does,
have
she
the
does
right.
environmental.
She
The
doesn't
environment,
nurse.
we're
She
talking
can't
about
change it.
environmental
I
concern.
understand, not
Has to
only.
be- has to be
The
an
environmental concern
Uh-huh.
is the only one I can
RN
change.
can do it.
The RN can do
Even an
it.
LVN can't do it.
Yeah.
Yeah, the environmental
Yes,
concern.
that's the one I can
call
do.
you many, he said talk to the case manager, is the only one who
But
can
just,
take
but
it up.
don't skip over it. If it's something that's happening over and over again and
Yeah.
you're not getting a response, don't skip over it. You know, if you wanna send me in an email the names of people that,
That's
whose
nice,
care
that's
plans
good.
need to be changed, do that. And I'll review it and I will get to the case managers.
Is this only for hospice?
Only for, I can't do it for home health. I don't have any jurisdiction for the home health.
Poor man.
Well, then I think if you, like I
Home
said,
health, I always
copy
call
them.
them though.
Hmm?
I always call the home health department. I always call them and tell them about the patient. Like I had home health patient, they put a shower there. Then I call, they still put a shower. I went straight to Tracy. I said, who will I talk to? Then Tracy took it off and put a bed back.
Mhm.
Sometimes that's what I do. When I'm so frustrated, I went straight. I ask them, who do I talk to? Because I can't be doing this. If you don't take it off, I'm not gonna see the patient, you know? So Tracy took it off.
Mhm.
So that's what I do. I go to them, you know?
Yeah, yeah. See what, I think, one thing that happens is the admission nurse, when they go out and admits the patient, they do the original plan. And then the case manager sees the patient for the first time the next day. And I think some of the case managers aren't looking at that plan. And it may not be appropriate because that admission nurse doesn't really know that patient after just seeing them one time. There's a whole lot of stuff that admission nurse has to do that. They spend they're there for 3 hours. A whole bunch of stuff they have to do to get that patient admitted, and then the case manager goes there. And after a couple days, they get to know them better and know what their needs are. And so I think that things are kind of falling through the cracks that way. And then when the patient's condition changes, then I think maybe the case manager forgets that they need to go back into that care plan and change it when things
That's
Change.
very, very
Is
important.
that possible that whoever goes and see a new need, either social worker don't make orders, but a case manager, to see what the needs of the patient, like diapers or wash basin, whatever, and make the order, and not wait for us to show up, and the family members are expecting us to bring everything, including towels, body wash, and everything. They
Everything.
have to explain the patient or the family members, this is what we want to provide. And whoever goes and see the patient, make the orders. Don't wait for us to show up. That happened yesterday to me.
Always happen.
That happened to me yesterday. The family was very upset. They called Margaret. Susan called me this morning and she wanted to explain what happened, so I explained her. But the family was very upset, disappointed with all of us. So we go there to
Some of the
serve.
nurses do
and-
that, maybe,
and
I
we
don't know
have
if there's
to
certain
be-
nurses that don't.
Yeah,
Some
some-
nurses
Yeah,
And so I told Susan, tell the nurses, whoever goes there, just make the order because they're expecting us to bring everything. And they
The
have to tell
first
them
time.
the things that we order.
Especially first timer patient.
And even though it's not a patient, they need stuff I order. Because, I mean, that's one of the,
And then you don't know if the patient uses pull-ups or diapers. We usually only have diapers. So if they wear pull-ups and they're out, they're like, well, where's the pull-ups? Well, we don't carry pull-ups. We have diapers while they don't wear diapers.
Yeah.
You know, and they get upset.
And another thing, maybe you would tell the case managers or the admission nurse, sometimes you shouldn't listen to what the family said. The family will say, it's a shower. Then they don't put it down.
And I think
They
they
say, look at the
access-
patient.
It's what they say what they want,
And
not what they
that's what
can
they
do.
want, not what
Yeah.
they can do.
Like we want her
So
to take a
before
shower.
they put the shower, let them look at the patient. When I used to work in convalescent, they would do, anybody who go to admit the patient
Yeah,
will
evaluation.
assess the patient to see. So when the
Yeah,
family
okay,
said
okay.
a shower, try to look at the patient. It's just
First,
patient.
yes,
Before-
yes.
before you put, sometimes when we come there, we say, it's shower, why you?
They get upset when you tell them you can't
We
give them a
have-
shower.
I'm not so sure that, that the nurse can tell on the very first visit.
I think so.
Sometimes.
This is it for
They
them.
don't know if they can do it or not.
Talking about the patient.
This
for
is
a
it
second.
for
I have
them.
a new patient in Moreno Valley yesterday. They're asking for a joint visit and I see that on the admission note that the patient is 4'8" and 80 pounds. 4'8" height and 80 pounds. So I still send 2 people and I asked the home health aide, can you please let me know if I need to send 2 people for that, you know, to judge, you know, if
She
the
fights.
patient need to. And she said, oh no, don't send any to home health aides, only one can fit on her. I said, that's cool. Sometimes it happens.
They
Look
get
at the
upset
joint visit
when
that
they
we have.
say, oh, well, you're coming to give her them a shower, and then you get there and you know you can't.
Yeah.
Absolutely not give. And they get upset, like, well, the nurse said she was getting a shower, and I'm like, why, we can't. You know, that's too hard, it's a risk for them and us. They get upset.
First of all, we have to see that everything is safe for us, for the patient.
Yeah, that's
and
what we
the-
have to do.
And if we're using a bench or a shower chair, whatever. Because sometimes, like Tuesday, we went to shower a patient and it was hard, very hard. Because this patient was with another hospice, but he was okay for shower. But he started declining. So when he started declining, they don't want to help him. So, and the family still expect us to shower them when
Right.
they're not willing to help at all. So that happened Tuesday with us
She
again.
was very upset.
And the wife was very upset, calling the office. And we kind of
She even
come
wanted
forward
us
and
to
do
put
our
the
thing.
patient from the shower to the toilet, I'm like, that is impossible.
Maybe it's
And
What
no
do you
room.
mean? You
There
don't
was
know
no
how to
room
do your
there.
job? How long have you been working there? 7 years?
is that?
Salazar.
Salazar, we
Eloy.
saw her yesterday.
You can
We
shower?
saw him
You shower him?
yesterday. Yeah.
Remember that?
But
election,
it was hard. He won't stand up. I
Okay.
am dressed. The second, I think that's
It
the
was,
second
it
time.
was okay for you to shower him?
Oh, now, but I will say we're gonna tell the case manager it's not good for shower.
We already told
Because
them.
Yeah, we already told
But
her.
I
We already
am still
told
there.
It's already see 2.
And then another thing, the patient just
And
sitting in the
then when
bench,
they
you cannot
when
watch
they
them
couldn't
behind.
do it, then
You cannot
Johnny
shift
sent
anything
the two ones who can do it.
I feel sorry
That's
for
why
you.
he's saying I am dressed.
No, no, because that's the adapter regulars, that you see this.
No, we're not regular. I'm not.
No?
That day was the second time.
That's your regular.
Yeah,
all the
it's
time.
first time, race for the first time. See, it's just like a chain of reaction.
Yeah, and when we tell the case managers, we cannot put them in the shower, but, you know, we only go that time and there's somebody else's patients, they don't do nothing about it. So,
Then they sent us on Wednesday. The girl told us, she said, people came on Tuesday, maybe they couldn't give him a shower.
no, it was hard.
And not only that, the family member get upset, they don't understand.
Yeah.
And we try to be
Yeah,
nice
because
and
they understand that
polite,
we're gonna
but
come over and give them a shower, they get happy because they cannot do it. But when they said that we're gonna give them a shower, they're expecting us to lift that pension and give them
yeah,
a
like
shower.
we're superwoman, like, come on.
It's impossible.
The
Some of
first
them
time,
are even joint visits for bed bath and they put in shower.
Oh, yeah.
Yes. And
the
I go,
first time we went
special
there,
shower? Oh my gosh, you
the
can
wife,
barely
we
move.
gave him a shower and
We need two
everything.
people
The
for
wife
bed
said,
bath.
did we give him
But
a
they're good, I send a
What
message
did I
to
say?
shake for bed bath.
dry
It's okay.
shower?
Dry shampoo?
Dry shower.
Well,
What's that?
yesterday we had a staff meeting yesterday morning, so, in that staff meeting, we told the nurses that, they can't have, two kinds of baths on the home health aid assignment, so it can't say shower and sponge bath on the same. But what they can do, but we don't want them to do it on every assignment, is there is one intervention that says other bath, and there's a box where they can write it in, where they can put may have shower with bench. If patient
Able.
refuses, they can have a sponge bath.
I saw that.
But we don't want every nurse to put that down, because if the surveyors come and they see it on everybody, they're gonna question it.
So what's a partial bath?
A partial bath is
They help support.
just pretty much face, hands, back, peri area, maybe
That
legs.
Nothing
That's
that is
a full
not,
bath.
That is
Not
a
practically,
That's
but
a full bath.
nothing
Yeah.
that is not complete.
That made me
I
confused.
think, you know, some people would argue, but I think it's mainly just face, hands, underarms, peri area.
That's
No,
what I thought.
that's-
Yeah. But I've heard some people say legs,
Yeah,
but I think it's
when
just
we
back.
watch legs
Still a
and
full
fat,
bath.
that's everything. That's a
It's
full bath.
everything.
Yeah,
Wow.
yeah. So, you're gonna see some changes, but, I can't get nurses to change the care plans unless I know that there's a problem with the care plan. So you have to let me know, because I can't look at every patient's care plan.
I noticed there's a new box on there, it said, viewed, the patient's chart was viewed on 3/9
Yeah.
by nurse such and such,
Reviewed and updated.
and updated, exactly, that's the new one on there. I
That's
seen
what they're
today.
supposed to do. And
I
they're
see.
supposed to do it on research,
Okay.
yeah. So, hopefully the other thing, I think they have a little bit of a difficulty, because we looked at, when they're reviewing it, they have this little window, and they can't really see the whole thing. They just see on this little window, so part of it's cut off. So someone was telling me that's the reason why we may be seeing some weird things like an IV when the patient doesn't have an IV, because they can't see it all. And it's just the way McKesson is. There's no way to make that window bigger so you can see
The rest of it.
the rest of it. But if we point it out to them, they can still take it off.
Well, you know what I'm doing now, because most of my patients, I know Sue is my case manager. When I see something that is not supposed to be there, I don't even send email, because it seems like email doesn't work. So I just call her on the phone. I talk to her, I say, Sue, can you please take this off? It's no longer, I think it's been working, Like some of them, they said two people are sick. If I find out it's only one person, I'll just call her. Sue, can you please take it off so somebody else will not go there and wanted two persons, are sick.
Yeah.
So I
It's-
think
That
that's working.
probably works to just,
You
either do it while they're in the office, ask them to take it off if you can, if you see them.
Or when
Or
I see
call
them
them,
in the
because
field,
if you give them a whole bunch of them, because they get so many phone calls and they have so many things on their mind, I think they're gonna forget to go in there and do it. But if they have their computer right in front of them, and if you see them in the office and you ask them to do it, they might pull it up and do it right then, because it doesn't take very long to do it. But if you keep emailing your case manager, and, you know, if you've done it twice, emailed them twice and they don't do it, email me. I'll look at it and then I can email them, they'll respond.
Like for Charlie, like doing the documentation and everything like that, I know it's different on home health, but they're all under like one umbrella, like Medicare pays for everything, I believe, or is it private insurance or the VA or something like that?
What?
Say like documented like wound care, like the patient has wounds, open sores on his body.
What about it?
It's kind of like, you document it, you keep documenting it, but nothing seems to be happening. I mean, yeah, I'm not gonna say any names, but it's really bad, and that smell and that, it's an odor there, it just,
So you identified that there's a wound there, and so you've done a
Documented.
mobile care note to the nurse and
Yeah.
nobody's doing anything about it?
well, he told me yesterday that they seen it last month. I said, really?
And they're not doing anything about it, or?
Well, they're trying to get him in a hospital bed because he sleeps in his wheelchair,
Mhm.
and it's really bad. He's huge too, he's a big man. It's just pretty bad, he's diabetic also.
Well, I don't know what more you can do. If you have documented that you have notified the nurse, then it's on the nurse. You're free. You can't.
Wear a
you know.
mask.
Hmm?
I do. It's powerful too, it's
Put
really.
Vicks on your nose.
The weeks?
Oh, yeah.
And you won't smell anything.
Oh my God.
And a mask.
Oh, he's a surgeon.
Or
And it could be a case where the patient's refusing to do what they've asked him to do.
He has a hospital bed in his room.
And so he's
in his
refusing to
room.
get into the bed, so what can they do? They can't do
How do
wound
you
care
do
unless he
that?
gets out of the chair.
And he asked me if I could move the bed, and I was like, well, I can't do that. I can't do that. Because they won't come out and move his bed unless there's something wrong with it, but there's nothing wrong. He's never been in it. I don't think he's ever been in that bed.
And he's never gonna heal up
No,
unless air gets to it, and
And his
it's
legs.
probably infected.
they come out through his legs. That's it. And it's just,
And he doesn't get up?
no.
Oh, yeah.
He used, yeah, he can stand, he used to can stand up, but now he's got some of these sores down there. He said, just get it over, get it done quick. And he really don't want you to touch it.
Is that good?
And it's bad. That smell is bad, really,
Sounds
really
like
bad.
I used to have a patient like that. That patient is in Laverne? I'm sorry.
No.
No, it's in
Rancho
Rancho, he lives in
I used to have one like that too.
From his
What's in
window, you
Rancho?
can see the pool. I saw him once.
Yeah,
There's nothing they can do sometimes because they're always on the chair and they refuse to go to bed. There's nothing the nurse can do in that case.
That reminds me, another thing I wanted to talk about was documenting when you see a wound or a bruise or something on your patient, when you do a mobile care, is that not to name it a bruise. If you see what you think is a bruise on somebody, just call it a discoloration and describe the color, the size, and the location. When you're doing the size, how do you document the size?
Just like the size of a penny or the size of a quarter.
Right, you compare it to something that everybody knows the size of. So a dime, a penny, a quarter, a half dollar, yeah, a golf ball, an orange, a lemon, something that everybody's familiar with that. But don't call it a bruise, call it discoloration. You can describe the color,
Or
the
redness?
location, and the size.
Can you call it redness?
Yeah, you can call it redness. Yeah, and if it's a sore of some kind, you can say it's a,
pressure sore.
pardon?
Pressure sore, no?
Can you say skin breakout?
Yeah, you can call it,
Down.
you could call it an open area. It's red. It's a size of a dime or whatever. And be sure too that when you identify it, if you're in a facility, make sure that the charge nurse knows about it. And if you can, make sure that they know about it before you finish your cares, because you don't want them to say that you did it.
Yeah.
Okay, so as soon as you identify it, you want to let them know Because if you wait till the end of it, they might say, you know, I would hope that nobody would do that, but it's possible,
Hugh did it.
yeah.
Hospice.
Yep.
You're not going to report it to another nurse's aide, right? You're gonna tell the charge nurse, because you never know if another nurse's aide, they're not the person you report it to. Okay, and then if you're in a home, you report it to the caregiver as well as, of course, you're gonna report it to the case manager.
Most of my patients, Janelle, most of my patients, Janelle is the case manager.
Mhm,
And she already told me she's off on Mondays.
mhm.
So I know she doesn't work on Monday. And when I'm having my day off, I tell her when I'm not coming to work. So, but if I go visit a patient and there's something, I call her on the phone. If she doesn't pick up the phone, I leave a message to please call me, there's something I need to discuss with you. She always returns my call. But for another case manager who I'm seeing somebody else's patient, and after working with them, I know those ones that won't do anything, so I call her. When are you seeing this patient? I'll make sure we're there together. Then whatever I want to show her, like the redness, I will mention it before we go inside, and I'll tell her, that's why I want us to be here together, so you can take a look at it. In that case, that tells me she saw it too. So then she'll decide what is the best thing to do. I'll tell her the last visit when I saw it, I had camo on it. I called you, I told you. She didn't call me back to say she got that visit. So the next visit, I called her early in the morning, asked her if she was seeing that patient that day. She said, yes. What time are you going there? Oh, between 11 and 12. Okay, I'll be there too, because there's something I need to show you. It works for me. Because she's not my regular. And she had been my regular, but I noticed she's the kind that would let you slide by. If you don't pin her down, make sure she sees it.
Mhm. Yeah. Okay, let's take the quiz so you guys can get out of here. You gotta make sure that you write your name where it says employee name and the date. And you sign where it says employee signature. And when you're all finished, make sure you fill out the evaluation. We're gonna take it together. Okay, number 1. It's best to perform all your care on all your clients first.
False.
Wait a minute.
No, it's true.
I didn't even finish. It's best to perform all your care on all your clients first, then sit down to document everything all at once.
False.
All your clients.
What?
No, that's
Or your
true.
client.
No, right? How can you
You
not
see?
right?
That's true.
No,
No,
that's,
it cannot
he's
be.
talking about all your
That's
clients.
true. It's false.
False.
It's not all your
No,
clients.
you do all the care on your client, one client, then you document.
Oh, I'm client. One client.
To me, that's a trick question.
So
You
what
really
is
have to read it.
False to
False.
S, clients.
Clients,
It's not a client, it's a client.
yeah, false. Okay, number 2, you can use any abbreviation you like as long as it is neatly written.
False.
False. You can only use approved abbreviations. You guys don't use abbreviations though, because you're just using your telephony plan documentation. Number 3, if your client refuses care, you should not document anything in the chart.
False.
False. Number 4, after making an oral report, you should document the name and title of the person you reported to.
True.
True. Number 5, your client tells you, I'm sick of living in pain like this. You should report
C.
no.
Suicidal?
C.
No, that's subjective.
His exact words.
Exactly what the client says. C, client reports, I'm sick of living in pain like this. Number 6, if you accidentally chart on the wrong client, you should use whiteout to cover the documentation.
Right.
False.
That's false. You never use whiteout in the chart.
Client.
Yes. Number 7, an example of an objective observation is temp 99.6, pulse 74, respiration 16.
True.
True.
True. 8, Keeping documentation confidential in a home health setting is not as important as other settings because most people in the home are family or friends.
False.
False. 9, it is never okay to document care before you give it, even if you do the same thing every day.
True.
True. You never document before you gave the care. You always wait till after you've done the care. Number 10, fill in the blanks. A report that describes an unexpected event that involves an accident or injury is called an
Incident report.
Correct, incident report. Okay, so fill out the evaluation, sign, and turn it in so you get credit. Make sure everybody signed the sign-in sheet.
Oh, you know what? And then they change it. Before you get hurt. Y luego yo la limpio y todo, porque se hace más fácil.
It's already done. Already, oh, we finished. What's this? Is it off already? Oh my God, I forgot. Stop. I think it's stopped already.